هنا دلوقتي احنا منا او كده. بعد ما خلصت المحاضرة فطلع البيت، فركبت الأسانسير، جارتها مدام نادية قالت لها انت مش في كلية طب في سنة كام؟ قالت لها في سنة رابعة. قالت لها طب انا بقالي يوم يعني حاسة ان انا مش شايفة كويس وعندي صداع جامد. فمنها هتفكر يعني مش شايفة كويس. طيب ممكن ده يبقى حاجة في الأوبتيك نيرف. طب أنا هقول لمدام نادية إيه؟ طب يعني إيه حاجة في الأوبتيك نيرف؟ فحاجة في مشكلة في الأوبتيك نيرف. ف آه، آه، الدكاترة قسموا الفانكشنز عشان نعرف في نورمال اوبتيك نيرف ولا لا، او ابنورمال اوبتيك نيرف. ان في 5 تيستس هنعملهم اللي انت قرأتيهم. فهتسأل مدام نادية، هتقول لها غطي عينك الشمال الأول. انت حاسة مش شايفة بعينك اليمين ولا عين الشمال؟ تقول لها بعين الشمال. طب غطي عينك اليمين. طيب تقدري تعدي دول كام؟ تقدري تقري الكارت ده مكتوب عليه ايه؟ فده الفيجوال اكيوتي. طيب منى طلعت لايت تورش، مصدر ضوء، بطارية أو مصدر ضوء، وقامت موجهه تجاه البيوبل بتاع مدام نادية، لأنها من عارفة حاجة اسمها إن في pupillary right reflex. فده فانكشن، يبقى هي بتعرف تقرأ وفي نفس الوقت في البيوبل رياكتيف. طيب في فانكشن ثانية مثلا الفيلد اوف فيجن. الفيلد اوف فيجن الفيلد اوف فيجن is an island of vision in a sea of darkness. طب يعني ايه؟ في حاجة اسمها مجال الإبصار. إذا إحنا دلوقتي مع بعض كل واحد فينا غطى عينه الشمال وبص على حاجة قدامه، طيب نزل إيده غطى عينه اليمين وبص على حاجة قدامه، طيب نزل إيده وبص بعينيه الاتنين في نفس الوقت. استخدم عينيه الاتنين إنه يشوف قدامه في نفس الوقت. فغطينا عيننا الشمال، ده الفيلد اوف فيجن بتاع الخاص بالعين اليمين. نزلنا غطينا عيننا اليمين. This is the field of vision of the left eye. We put our hands beside us. We didn't cover our eyes. يبقى this is the field of vision combined of both eyes. So the field of vision has been described as an island of vision in a sea of darkness. Why is been described like this? We can take a look at this picture. Here is the photoreceptors curve of sensitivity, light sensitivity for photoreceptors. Here's the peripheral retina, the sensitivity, the density of the photoreceptors, and then the vision increase till reach the end of the optic nerve. The edge of the till reaches the edge of the optic nerve. طيب الاوبتيك نيرف فيه ريسبتورز؟ من فضلكم حد يجاوب. هل في ريسبتورز فوتو ريسبتورز؟
هو الريسبتورز في الريتنا مش في الأوبتيك نيرف نفسه، يعني هو
طيب
يعني بيوصل السensation، يعني light sensations.
طيب if we shine light on the optic nerve, will the patient see or the person see?
لا.
طيب فيبقى السنسيتيفيتي هينزل تاني، وبعدين at the other edge of the optic nerve هيطلع، وبعدين as we approach the fovea there are few rods في الفوفيا. The fovea has cones. فالفيجن اللي acquired using the rods decreases when we come to the fovea, and on the other hand, because the fovea has a lot of cones, then the vision that is seen using the cones increases at the fovea. So if we outside this, there is no vision. So we test our field of vision by getting a target, a visual target, from the non-seeing area to the seeing area. This is did you take in your clinical skills class how to assess the field of vision using the confrontational method؟ ده سؤال ليكم.
يا دكتور خدني.
طيب احنا you get the target or the pencil or the finger, you start where?
المفروض midway ما بيني وبين البيشنت، يعني حوالي نص متر.
طيب and your finger you begin to move your finger from which point?
المفروض from upper temporal to lower nasal.
So you start in the non-seeing area. You and the person you're testing his field of vision, you don't see your finger, and then you move the finger towards the center or towards the like you described till you start seeing. Here we can try this test, all of us. We close one eye. Let's say we'll close our left eye. And we're closing our left eye. Then we're looking with our right eye at the letter R. And then try to place the eye at a distance from the screen, على مسافة من الشاشة, which is nearly 3 times the distance between R, the letter R on the computer screen, and the letter L. At one point, you're focusing, you're looking at R, then you'll find that the letter L disappears. If you get farther than this, if you get more away from the computer screen, the L appears. If you get closer again, the L disappears. Then if you get more closer, the L reappears. So at a point, the L, the reflection of light from the L falls on the area which we describe as the optic disc. And this area does not have photoreceptors, so you don't see the letter L. If you get away, then the reflection of light falls on the retina and stimulates photoreceptors. If you get much closer, then the letter L falls on the retina and stimulates the reflection of light from the letter L falls on the retina and stimulates photoreceptors. Here in this slide, here's a pencil. The light reflected from the pencil enters the eye, is focused by the strongest lens in the eye, which is the cornea, then focused by the crystalline lens, second most important lens in the eye, onto the fovea and the macula. Then we will magnify this area. Look at this arrow. This is the area magnified. So here the light, focused light, falls on the retina, passes through the internal limiting membrane, through the nerve fiber layer, through the ganglion cell layer, bipolar cell layer, outer plexiform layer, outer nuclear layer, till it reaches the tips of the rods and cones, where phototransduction starts. So the light stimulates the tips of the rods and cones, and then the phototransduction cycle starts with an interaction between the retinal pigment film and the rods and cones. And then the nerve impulse travels in a direction opposite to the direction of light, from distal to proximal, stimulates bipolar cells, then ganglion cells, then passes the nerve impulse passes in the axons of the ganglion cells, where it enters the optic nerve. So we'll return to this. The nerve impulse entered the optic nerve. Then at the part of the nerve impulse passes to the other side through what is called the optic dia. The optic what? So here's the histology section in the retina. The light passes through layers till it stimulates the tips of the rods and cones, and then the nerve impulse passes on the opposite side. So each eye looks at a picture. The picture stimulates the receptors. Receptors stimulate bipolar cells. There's interaction with horizontal cells. The bipolar cells stimulate the ganglion cells, and there is modification using amacrine cells. Then there is nerve impulse. So we remember together the optic nerve functions. Light perception. We test for light perception to know the nerve is functioning or not. We test for visual acuity. Then we test for what? Who is going to read for us?
Color vision.
Then we test for?
Field.
Then we test for?
Reflexes.
So here the nerve impulse passes through the optic nerve, then the optic tract, where the first synapse and the second order neuron starts in the lateral geniculate nucleus and then passes through the optic radiation till it reaches the primary visual cortex. So here, Dr. Ishihara devised or invented this isochromatic color plates in which a combination of different colors produces a number with a distinct color or several colors, where a normal person looking at this plate sees this number as what is this number?
6.
So, but a person with a defect or a problem with either red or green or blue will see this number as a different number. So we talked about the confrontational field of vision test. Here is in which the confrontation, the target, you move your hand, so the target is moving from non-seeing to seeing. So here, doctors and engineers developed another test for field of vision, which is called computerized static field of vision. Here, the person, as you see, is covering one eye and looking with another eye, with the uncovered eye. He's holding a button or a trigger with his hand. He's asked to look with his uncovered eye to the center of this ball كأنه نص كورة. يعني الفيلد اوف فيجن الجهاز ده فيه جواه حتة عميقة. There's a depressed area like a sphere. Here the patient rests his chin and uses one eye to look at the center of this sphere. And he is asked that if you see a light, press the button and don't move your eye towards the light. The light target can be yellow. Here there is a camera where the operator of the test looks and sees the patient's eye in one area, that the patient is following the instructions. يتابع التعليمات, who is looking at the center of the sphere. And here is a plot figure in which when the machine, computerized driven, puts a light on, you can know where the light was or where the patient pressed the button correctly. So the confrontational field of vision that you practice in the clinical cells, the target is moving. There was another field of vision test. Here's the sphere. The patient sits on this side, the operator or the doctor sits on the opposite side of the machine and moves the target, and the operator's movement of a target over a plot chart is translated into a movement of a target inside the sphere where the patient looks. And when he's instructed, when he starts seeing the target, to tell you at the point that the patient sees the target, you put a mark on the chart, plot chart. Then you move, you get from outside, then move again, another point. When patient says, I can see now, so you put another mark, and then you get the target away, and then move it. The patient says, I can see the target now, then you put another point. And after you make a lot of points, you connect them. And you use either use a color code or use a mark of some type to describe the light, size, and intensity of the target. So there are different points. If you use different light sizes and intensities, where the patient can see them. This is called perimetry. Here we remember with each other, here's the brain, some of the anatomy that might help us. Here's the lateral geniculate body, where the axons from the optic nerve, synapse, and the second order neuron moves out of the lateral geniculate body, starting the optic radiation. And in the optic radiation, here are dark brown and green fibers. The dark brown fibers are the fibers representing the superior retinal quadrants, so they see the opposite field, which is the inferior field. The green fibers represent the inferior retinal quadrants and see the superior field. You just reminder that there is the brain has arterial blood supply and a venous drainage. The internal carotid artery plays an important role with its branches anterocerebellar, frontopolar, and the vertebral artery with a basilar artery play an important role of the arterial supply. Here is the calcarine artery, which supplies the visual cortex. Here's the view of the brain from underneath. يعني احنا باصين على البرين من تحت. This is the internal carotid artery. What do you see here when you look at the brain from beneath, from below? Could you please answer the question?
The midbrain, the
Very good.
chiasma,
Optic chiasm. And here, this is a gland.
pituitary gland.
And then here is at this point,
cerebellopontine angle. I think.
Yes, and this might be the abducens nerve, the sixth nerve, with a cut end. This might be the oculomotor nerve, third nerve. And here is an artery, basilar artery, which connects to the internal carotid artery, which connects to the other internal carotid artery, which connects to the basilar artery. So this is an arterial circle. This artery, which is called the posterior communicating artery, sometimes when a patient develops headache, ptosis, dilated pupil, weakness in the direction of action, superior rectus, inferior rectus, medial rectus, inferior oblique, and you do imaging in the form of magnetic resonance imaging of the brain and this area, you might see in this patient who had developed ptosis and weakness in movement in the direction of action of the superior rectus, medial rectus, inferior oblique, you might see a protrusion from the artery or an aneurysm of the artery pressing on the oculomotor nerve. So here's the visual pathway, the eyes, optic nerve, chiasm. After the chiasm, it's called what? Please.
Optic tract.
And then reaches the lateral geniculate body. What happens in the lateral geniculate nucleus? What does happen in the lateral geniculate nucleus? The
Doctor, are you asking?
yes, please.
Yeah.
What happens to the optic pathway, the visual pathway in the lateral geniculate nucleus?
It relates in the first center, then it radiates to the brain.
Thank you. Here we just want to mention that there is a expression called parallel visual processing. Ventral what? Dorsal where? There's language processing, object identification, and visual spatial analysis. So the visual function, we can observe some components inside the visual function. We see something, but what is it? We see something, but where is it? We see letters, then we can view the letters as words, as language. We see keys, we know these are keys for a door or for a safe. So if there is a field defect, we might think of field defects as complete field defect of one eye. Please, who else wants to share?
I can continue with you, doctor.
You are Minna,
No.
Nada.
Yes.
So who is there anybody else wants to share also or participate? So here this picture describes if a lesion or trauma or something happens here, what is the field effect? So here is, if could you please, Nada, say this lesion is where?
In the optic nerve.
So it will produce loss of vision in
Ipsilateral one eye.
complete loss of vision from one eye, the ipsilateral. And here the lesion is where?
In the chiasm.
The peripheral of the middle of the chiasm, or which area of the chiasm?
The middle of the chiasm.
So it would produce field effect.
By temporal hemianopy.
So there, as you go proximal towards the brain, there is more organization of the fibers. So a region in the side of the chiasm will produce nasal field effect. And as you can see here, the field effects respect the vertical line. And as you go more proximal, then the macular fibers have a larger area. So it's more rare that a lesion will involve both the periphery and the macula. And as we said, in the parietal cortex, in the area where the optic radiation passes, if you high in the parietal cortex, then these are the fibers that represent the upper retina, so represents the lower field. More towards the temporal lobe, there is the fibers that represent the lower retina, so represents the upper field. So more to the temporal lobe, if there is a lesion, you can get upper quadrantic here it's in the right eye, so you get quadrantic left homonymous quadrantanopia or quadrantic anopia. If the lesion is high in the parietal cortex, then you get in the right parietal cortex, you get lower homonymous left quadrantanopia. If you get the lesion in the visual cortex, where the macular area is represented by a large space, then you might get homonymous central left homonymous defect, visual defect, affecting only the macular vision. This is outside your curriculum. It shows in detail the ordering and the distribution of the fibers from different retinal parts inside the optic nerve. As you can see near the chiasm, the fibers from the macula pass in the middle of the optic nerve, and also in areas of optic radiation. What is this picture?
Optic chasm and crossing of the nerves fibers, I think.
Here the artist wants to demonstrate that some of the crossing fibers make a small loop inside the opposite optic nerve. So pass distally and loop and then go back in the opposite optic tract. So if you get a lesion here, it will affect the left eye. If you get a lesion here, then this is the field defect you will get, affecting one eye and a very small area of the other eye. Did you attended the glaucoma session?
No, we didn't take it.
So this slide is important when understanding the glaucoma, that there is the nerve fiber distribution in the eye, in the retina. This is the right eye, right optic nerve, right fovea and macula. As you see, the nerve fibers enter the optic nerve. But if you keep track of them, this nerve fiber was coming from the upper retina, then enters the optic nerve. Here, keep track of nerve fiber, comes from the upper retina, from the upper retina, from the upper. Here you start with fiber, here comes from the lower retina. So here the nerve fiber layer respects a horizontal line, which is described in this drawing as RAFI. Nerve fibers respect this horizontal line directly. So here we want to help this patient who was in the elevator and complaining of loss of vision and headache. So we want to help her know what is the disease she has and what treatment to take. So we ask her some questions, and we call this history of the disease. So we ask her, when did this loss of vision start? What is it 5 minutes ago, or 5 months ago, or 2 years ago? And is it increasing or improving, or same situation over the past period? So we call this onset and course. We ask her if she had trauma, or is taking medication, or uh, she had this before, and this is the second time or third time this happens. We ask her. If she is a smoker. Does she use narcotics? Uh, we ask her about her job and work, so we know what is the visual demand for this job or work. Then we do what we described before as the tests for optic nerve function. So please read what are the points of examination.
First, ocular motility, then cranial nerves, 7 and 8, vision, color, and acuity, field of vision. Investigation, imaging, and visual effect potential.
So here is the part of the ocular motility in which this woman was asked to look upwards. Here, look in my face, then look upwards. So levator palpebrae superis is working, superior rectus is working, inferior obliques are working. Look downwards. So inferior rectus is working, superior oblique is working. We want to make sure that the right superior oblique is working good. Then we tell her to look downwards towards the left. So here, in adduction, the main depressor of the eye is the superior oblique. In abduction, the main elevator of this eye is the superior rectus, but in this eye is the inferior oblique. So this patient presented, has bandage over his forehead, so he has some sort of pathology or trauma to his forehead. Then we do external examination. Here we can see that this eyelid what happened to this eyelid?
Yeah, I think this one is normal and the other is ptotic.
So, and the eye underneath here is looking upwards with the action of the superior rectus and inferior oblique. So, and this eye,
Ptosis.
look at the cornea also.
No light reflex.
So this eye look upwards, this eye cannot look upwards.
Yeah.
Here we ask him look to your right side. So this eye moves a very small distance and this eye moves normal distance. Sometimes you can, by inspection, suspect something and think of what is the examination or test or investigation you would use. Here you suspect that the right eye is protruding more than the left eye.
Doctor, is this in the third nerve palsy?
Pardon me?
Is this lesion in the third nerve palsy?
So if third nerve palsy happens, will the eyelid be open like this?
No, so
No,
it's not.
this is something pushing the eye, the eyeball
Ptosis,
out
yeah.
outside the orbit.
Not related to the previous case.
No, no.
Okay,
But
thank you.
here, if you this is the, what is this?
Which
Hmm?
optic nerve or optic disc.
Yes, so, and it seems normal. The color is normal. The cup is normal. The blood vessel seems to be normal. So there is something pushing the eye from behind, and the optic nerve is normal. Why are we trying to say the optic nerve is normal? Because it might be a disease of optic nerve itself, like glioma, optic nerve glioma, or meningioma, a tumor of the optic nerve that is pushing the eye. But if this is the case, the optic disc won't be normal.
Okay.
So optic nerve glioma has two peaks of age. It can occur at 7 years of age, 8 years of age, and then in much older females. So if the optic nerve was not normal and there was swelling of the optic nerve, so by definition, if the swelling of the optic nerve is bilateral, then we can call it papilledema. Except in a certain situation which is called Foster-Kennedy syndrome. If the swelling of the optic nerve is unilateral, we call it disc edema, and we describe right disc edema or left disc edema. So, but some disease that may affect the visual pathway, like vascular disease, stroke. Here we see that this is a computerized tomography of the brain and skull. And then looking at the brain, there is difference in gray scale in this area and this area. There is some lesion. And here it seems that the midline is pushed towards this area. So there might be some edema here. Here showed that there is a lesion. This lesion may, if it affects the knee of the internal capsule, it might present clinically as hemiplegia, hemianesthesia, and a field defect. If there is infarction of the knee of the internal capsule, then it might present as hemiplegia, field defect, hemianesthesia. There is one entity when we test the reflectors, it's called light near dissociation. We'll talk about it. Uh, and this light nerve association is sometimes related to syphilis, old long-standing syphilis, or a disease called syringobulbia. Tumors also may affect the cerebellum, or causing nystagmus or other cranial nerves. So we now move to the pupillary examination and the reflex examination. So the pupils to move, they have a nerve supply. There is the constrictor pupillae muscle and the dilator pupillae muscle, and these have nerve supply. So the nerve supply, according to the order of the nerve component, there is first order neuron, which passes from the retina, the pretectal nucleus. And then there's a second order neuron. So the first order passes from the retina to pretectal neurons. The second order neuron passes from the pretectal neurons to both Edinger-Westphal nuclei having bilateral innervation, and the third order nucleus passes from the Edinger-Westphal nucleus to the ciliary ganglion, the fourth order nucleus passing from the ciliary ganglion to the sphincter pupilla via the short ciliary nerves. Here this patient presented with, says the eyelids seem not normal. What is happening with this eyelid?
Also ptosis.
So here this eyelid is the marginal reflex distance is small than compared to this marginal lid margin light reflex distance. Here is normal, here it is smaller. Also, we notice what about the color of this eye with the color of this eye?
Heterochromy.
So there is difference in iris color. This patient might complain of that one side of his face does not sweat as the other side. Then we suspect, and he might notice this, one pupil is different size than the other pupil. It is smaller. So the sphincter pupillary muscle is supplied by sympathetic supply. Or the dilator pupillary muscle is supplied by sympathetic supply. What do you suggest?
The dilator.
So this pupil is smaller, then there is problem in the sympathetic supply, with the parasympathetic, which supplies the sphincter pupillary, taking the upper hand. So we want to make sure that this is Horner syndrome. So we do, if it's available, apraclonidine eye drop test. uh, or cocaine test or hydroxyamphetamine test. And this test, this pharmacological test, may exclude drug-induced anisocoria. So anisocoria is an entity when examining for neuroophthalmological pathology. And one Dr. Adi described a situation in which occurs more commonly in females, in which there is unequal pupil size, and when you direct light, here is light source, directed in right eye, the pupil constricts. When directed in the left eye, it does not constrict as much. However, when you ask the same woman to look at a near object, target or visual target, both pupils constrict. So the reaction to light is not normal, but the reaction to near vision is normal. So there is dissociation between light and near vision reflex regarding the pupil. And this is usually a unilateral problem, and after years might become bilateral. Usually in females, Dr. Adi described it in females more commonly, and with another doctor called Holmes, in which he described a situation in which this woman might have decreased, depressed deep tendon reflex when you tap the Achilles tendon or the quadricep tendon, then the reflex is depressed. The extensor reflex is not normal. And sometimes this woman might, when she's lying, might get hypotension, blood pressure decrease when she's lying flat on the bed and asked to stand up at once, and she might get postural hypotension. So adystonic pupil, please read. Please read.
Diagnostic features of tonic pupil include sluggish segmental pupillary response to light and better response to near effort, followed by slow articulation. Atonic pupil is caused by both ganglionic parasympathetic pupillary motor damage. 70% of patients are female.
So here is an exception of male patient, and as you can see, are the pupil equal in size? Are these pupils equal in size?
No.
So it might have many causes. One is pharmacological. You can ask the patient. It says they give me the eye drops half an hour ago, and they told me these eye drops will open your eyes so that we can examine the retina. So this is drug-induced anisocoria.
Yes.
But actually, you ask him, did you take eye drops? No, I didn't take eye drops. Even 2, 3 days, 4 days ago, 5 days ago. No, I didn't take eye drops. Then you shine light in the pupil and observe which pupil constricts. And then you ask him to look at a near object like a phone or near vision chart. So this aditonic pupil is unilateral in most of cases.
although after a long period, the other eye may be affected. So please read.
Tonic pupils are unilateral in 80% of cases, although the second pupil may later become involved 4% per year. Homozygous syndrome include other features, notably diminished deep tendon reflex and orthostatic hypotension.
So here the denervated, because this is post-ganglionic lesion, so the iris sphincter is super sensitive to topical parasympathetomimetic eye drops. So you can get commercially available pilocarpine eye drops, which is usually 1%, 1%, and then get 1 milliliter of this eye drops and dilute it with 9 milliliters of a solution, a physiological solution, to produce 0.1% eye drops. So normal pupil rarely constricts if it to 0.1%, but constricts to 1%, which is there is a 10 times difference in concentration. So you use the very diluted eye drops and putting it in both pupils to test if there is denervation iris sphincter supersensitivity, if there is postganglionic lesion, posterior ganglion lesion in one of the eyes. So you put 10 times diluted pilocarpine eye drops. These don't have an effect on the normal iris sphincter. But in the eye where there's postganglionic lesion, this strength of pilocarpine may cause constriction. Not in normal, but in super sensitive iris sphincter. So, is there another person than Nada want to read with us, please? Another person want to read?
Doctor, I think no one is present.
So please proceed.
Okay. Roger Robertson. The Roger Robertson pupil is usually bilateral, and the size of the pupils may be unequal. Absence of the characterized by small irregular pupils, light reflex, a proper accommodation reflex. Pupils slowly dilate with mydriatics. I will continue, doctor.
Please.
The most common cause of this condition is syphilis. If the etiology is syphilitic, then the pupils are generally unequal and irregular. Also, there is atrophy and depigmentation. The ciliospinal reflex is lost.
So here is a video posted by Dr. Kathleen, and this video was made by the late doctor, and here so you got what the night near dissociation with Argyle Robertson pupil. The
Yeah.
pupils are small to start with, but they poorly constrict to light. When you ask the patient to look at a near object, they rapidly constrict as a part of the near reflex. And then when the patient looks, this long-standing syphilitic patient looks far away, then the pupils, the constriction stops and the pupil dilates. So when you were discussing with your neighbor while going up in the elevator, she says, I have pain, I have loss of vision. You have in mind what we call differential diagnosis. You have many, you studied many diseases. So we're thinking what disease can have this clinical picture, this history of this woman going up in the elevator with you. And then you have an organization that there are within these several diseases, there are more urgent disease that there are some diseases that don't need urgent attention. You can visit the doctor next day, the following day, after 2 days, take an appointment. But there are some diseases that are more urgent. Example is, please read.
Compressive vasculopathic third nerve palsy, acute anterior ischemic optic neuropathy, pituitary adenoma, and Horner syndrome.
So what, after doing the previous examination, you can ask for tests, investigation. You can ask for blood glucose, for erythrocyte sedimentation rate, C-reactive protein. You can ask for a computerized tomography angiography for a magnetic resonance imaging of the brain optic visual pathway of the orbits, examination of other cranial nerves, and if there is headache and there is tenderness over the temple, and there is indurated temporal artery with acute imminent vision loss, you can ask for a temporal artery biopsy to observe for giant cells. So here is the question. Would you like to suggest an answer?
Assess the pupil.
Yes, please.
So I would assess the pupil.
Yes.
And the fundus. I can make fundus examination.
Yes, please.
Also, field examination.
Please, yes.
Visual acuity by color discrimination.
Yes, very good.
I can make a general examination for the eye, for example, for red eye.
Ocular motility.
Yes.
She might have ptosis that's covering the eye.
Yeah.
Thank you so much.
Thank you, doctor. Thank you.